So hi, everyone, and welcome to our fourth Revolutionizing Healthcare session and our first session of 2021. Thanks very much for joining us. My name is Nick Maxfield. I handle the Schaar Lab's communications, and I'll be moderating today's session. I'm also joined by Mihaela Schaar, who will be giving our presentations in the session and will be answering your questions. Also with us as co-moderator is Alex Chan, who's one of our lab's PhD students. So to give you an idea of what to expect from today's session, ongoing goals for revolutionizing healthcare are to build a shared community and to develop a common language between machine learning and healthcare. And we aim to do this by defining and understanding medical problems through the use of academic formalisms and by mapping these problems which are raised by clinicians to AI and machine learning solutions. The focus of our next two sessions will be on cancer. This session will be particularly looking at the earlier parts of the cancer pathway, by which we mean, for example, risk, lifetime factors, screening, presentation, diagnosis, and so forth. And then in our next session, which will be at the end of February, we'll be looking at subsequent parts of the cancer pathway. And both of these are a little bit general in approach. At some other point, maybe later this year, we do hope to make some dedicated sessions in which we look at specific aspects of cancer in a bit more detail. And the format of today's session is as follows. So after my intro, I'll play a short video by Mihaela in which she'll lay out what to expect in today's session. And then we'll have some self-introductions from the cancer experts who kindly volunteered their time to talk to us ahead of today's session. We'll then play a video in which these experts introduce their problems and questions in the cancer domain. And then we'll have a presentation in which Mihaela basically tackles these problems and questions through the use of formalisms and maps them to AI and machine learning solutions. We'll then go into a roughly 15-minute Q&A and open discussion on all of these points that I've mentioned above. I would like to ask you, if possible, to post your questions into the Zoom chat during the presentation. The earlier, the better, and please address them to everyone, not just to me. And we would like to limit our questions, if possible, to practicing clinicians, since you are our target audience for these sessions. We hope to wrap up at just about 5:10. So before we get started with the actual kind of content of the session, I do need to make a quick kind of declaration. So as a lot of you probably now know, we're now able to offer CPD or continuing professional development credits to UK-based clinicians who are participating in revolutionizing healthcare. It's basically 1 credit per session. But in order to do this, I do need to make a kind of declaration of interests. So the Revolutionizing Healthcare series is a non-commercial, no-fee event organized by our lab independently from our research sponsors. We don't have any conflicts of interest, such as financial relationships that would undermine the balance, objectivity, or scientific rigor of these sessions. And we won't use these sessions to promote products or services. If we do mention one of our research sponsors, it'll be because it's strictly relevant to the academic content of the session, and we'll acknowledge the sponsorship relationship whenever we make such a mention. If you'd like to know how to claim CPD credits, I'll give that information at the end of this session. Anyway, without further ado, I'll now introduce Mihaela's short video in which she kind of lays out the purpose and the structure of today's session.
Good afternoon, everyone, and welcome to the latest Revolutionizing Healthcare. This is the first of 2 sessions we will do on cancer. As you will all know, cancer is not one condition. It is complex and difficult, and the cancer pathway is complex and involved. So this is why we split it into 2 sessions. In the first session, we are going to look at genetic risks, lifestyle factors, presentation, and diagnosis. And what I would like to do in the next hour and over the next session is look at where machine learning formalisms and methods can truly revolutionize our understanding of cancer disease pathways. The other thing that is attractive about cancer as a disease exemplar is that due to the complexity of the condition, what we can learn from cancer can be applied to a whole range of other conditions. But first, let us hear from several cancer experts about the challenges they face in dealing with this complex condition. Good afternoon, everyone.
Okay, so next up we have our self-introductions from the cancer experts who kindly volunteered their time to talk to us ahead of this session.
Carlos Caldas. I'm an oncologist and a scientist, and I work in the hospital, but of course I'm a researcher and lead of a big research group at the Cancer Research UK Institute.
I am Dr. Patricia Gans. I'm a medical oncologist at UCLA, a professor, and I am an associate director for population science in the UCLA Johnson Comprehensive Cancer Center. I'm also very interested in cancer care and quality of care and healthcare delivery in cancers.
So I'm Fiona Gilbert. I'm a radiologist. I'm professor of radiology at the University of Cambridge. And I'm a specialist in breast imaging. That's one of my main areas of clinical expertise, and also musculoskeletal imaging. But more recently, I've become particularly enthralled by artificial intelligence and what it can do to help radiologists in their working lives.
My name is Vincent Yanopragasam. I'm an academic urologist with a specialism in prostate cancer. I work at the University of Cambridge and Cambridge University Hospitals Trust in the UK. And I'm very interested in risk modeling and individualized management of patients diagnosed with prostate cancer.
Hi, I'm Kelly McKeon. I'm a breast oncologist at UCLA. I have a PhD in cancer biology from Stanford, and I primarily specialize in breast cancer treatment, research, and prevention through a high-risk clinic.
I'm Ani Purushottam. I'm the director of King's Health Partners Comprehensive Cancer Center. I'm a breast cancer surgeon and an academic with King's College London and Guy's and St Thomas's NHS Foundation Trust. For 3 years, I spent half my life in India working for the Tata Trust cancer care program based in Mumbai, setting up cancer services across 7 states in India, and having developed the program at the end of December, left to come back to be full-time in London.
My name is Vasilis Stavrinidis. I am a clinician by training. At the moment, I'm doing a PhD at UCL under Professor Mark Emberton. The main theme is prostate cancer. And my main interest is basically the use of MRI to diagnose prostate cancer and also understand a little bit more about the biology of the disease using imaging.
I'm Henk van Weert and I'm a general practitioner in Amsterdam. I've done patients for about 30 years. And now since the last 8 years, I've become in 10 years, I've become a professor of general practice at the Amsterdam Medical Center.
Okay, so next up we have some clips from our actual discussions with these cancer experts in which they raised their problems or questions related to the cancer domain. And as you'll see, these really form the substance of how we address our development of formalisms and answers in Mihaela's subsequent presentation.
The moment we find out that somebody has cancer, he probably has it for several years. So there is a large window of opportunity in early diagnosing cancer. We refer about 80% of the patients within 2 weeks after presentation of the first symptoms. So that's done pretty good by general practitioners. The problem is that although we do it well, about half of those patients has a disseminated cancer. So that are patients who are going to die of it, or who's going to face a real troublesome trajectory in treatment of that cancer. So they will have a chemotherapy or at some form of a systemic therapy anyway. And the ones who are referred in a localized stage can probably be helped by some minor surgery sometimes. So a lot is to gain by referring those patients earlier in their trajectory. I think the biggest problem here is that we don't know we are looking for that cancer. The moment that the GP thinks that the patient has a lung cancer, he will know how to diagnose the lung cancer. But the problem is that you don't think of it. And we know we have some screening tests, but then, I mean, for example, if you look at the positive fit test that's used for colon screening, the screening of colon carcinoma, you see that the positive predictive value of a positive fit test for cancer, at least, is about 5%. So that's not so very high. And of course, if you can saturate the population before the fit test, the positive predictive value will become much higher. So that's the place where we can make much progress if we know something, if we know some variables, some pattern where we can look for as a well in our idea about raising the prior chance of having a certain kind of cancer. I mean, there is always genetics, there is always a family history, there is environmental influence, and probably lots more, but we just don't know at this moment. So we have we cannot rely on identification of known symptoms. We have to find out some new information in identifying those patients. General practitioners, because they follow their patients sometimes for 10, 20, 30 years, have some information on, have additional information on patients which they are not aware of. Might be family history, but it also might be a combination of symptoms or a timeline of symptoms, or I don't know exactly what, but there must be something around there which is not operationalized at the right way at this moment.
A lot of our current risk is determined by whether or not somebody has a BRCA1 or BRCA2 mutation, but now we know there are a lot more genetic mutations that can predispose a patient to breast cancer, but we don't know those exact risks because we haven't been testing for those genes for all that long. There are a lot of patients who are high risk for breast cancer based on family history, with clearly a hereditary component, but no one single gene that's actually causing their predisposition to breast cancer. There are a lot of other components that could be gene-to-gene interactions or epigenetic regulation. I might have a BRCA1 patient who has a family history of absolutely nothing, and her risk, if she came into my clinic, would be predicted to be 90% or something until you take into account her family history. So all these things that there's just no way for us to figure out all that complexity. But there's going to be an increasing amount of these complex models that will come out with showing gene-to-gene interactions that will need help in interpreting. But I think that machine learning could potentially help us with.
We know that almost half the cancers in London are preventable, and they're related to tobacco, alcohol, and obesity. If we can start thinking in terms of the human being who's out there and being exposed, and these are environmental exposures, and being exposed to a higher risk of developing cancer as a result of this, then you immediately have the opportunity to see how machine learning can play a part in that human being's existence in terms of their risk factors. Now here there are risk factors that are avoidable, and there are other risk factors that are unavoidable. And the unavoidable risk factors may be germline mutations for particular types of cancer, for example. So that you can start from prevention. In terms of the big problem that we still have, even in developed countries like the UK, is the patient recognizing what we call red flag symptoms and then going to the primary care practitioner, and the primary care practitioner then identifying those red flag symptoms in a timely manner and then referring that patient on to the secondary care, tertiary care provider to get a diagnosis of cancer. And there's often a huge delay in that process. And there are many reasons for this. Patients don't want to disturb their GPs. Patients don't want to acknowledge that the symptom they have is actually of any relevance. They go to their GP. GPs in their lifetime will see very few cancers because their practices by nature are small. So it's really important that they have an interest in cancer and really understand the signs and symptoms, so that, and not all signs and symptoms are straightforward. So is there a way that machine learning can play a role in the education of patients and the education of the primary care practitioner to enable the patient to come to the hospital? So are there algorithms that can be devised that make it much easier for the primary care practitioner to identify this is a risk, this is a high-risk patient, and this patient needs to be seen at the hospital to get a diagnosis and treatment?
What everybody that doesn't have cancer wants to know is what is their risk of getting cancer, and what is their risk of getting cancer in a dynamic way. You know, it's totally different to think about that when you are in university and you are in your 20s to when you are in your 60s. And so I think, you know, ways of using data-driven approaches to refine risk stratification is one area, and increasingly doing this dynamic modeling, because it's not just in one time point. It's going to be, you know, as individuals are moving, and they're moving chronologically because they're getting older every day that goes by, and as other things happen or don't happen to them, that you can adjust their risk, you know. So if, for example, they become obese by the age of 50, and they were not obese by the age of 20, by the age of 50, the obesity is increasing their risk of getting cancer by the age of 70 to a greater degree than if they were 50 and not obese.
In contrast to many other diseases, there are multiple cancer screening programs. So you're trying essentially to detect a disease at a preclinical level to treat it early. And that's a little bit different to many other diseases, for example, like infections, where people manifest the infection only after they basically contracted it. So that's where you treat, you have a much more reactive approach to treatment, whereas in cancer, you have a proactive approach. And in order for screening programs to be successful, you have to understand the natural history of the disease. And you need large data sets. You need to understand how the disease evolves over time and pick, again, the window, the appropriate window for screening, which has to be determined in a quantitative way.
Where does AI really impact in an effective way, in a cost-effective way, which gives the best patient outcome? Radiologists are reading huge volumes of the same type of data. So an example is mammographic screening. In the UK, we're screening over 2 million women each year. So this is an enormous volume of work. In other countries, the States, some of the countries in Europe, which have organized screening programs, the numbers are even greater. And so to have a tool, a robust tool, which doesn't get tired, it doesn't get emotional, it's performing in a very consistent fashion, is hugely helpful. Because in many countries, these images are being read by two people, two experts, because we know that if you have two radiologists reading a mammogram, then the second radiologist will pick up between 6 and 10% additional findings, additional cancers actually. And so AI tools, if we can have one radiologist working with an AI tool, then it means that we save on manpower, we take the pressure off radiologists, we can filter the examination, so we can put we can use different AI tools which will either detect abnormalities, or there might be another artificial intelligence algorithm which can perhaps triage the cases, so that the cases where there's more likely to be an abnormality there, which is a cancer, the radiologists can read first when they're fresher, they're not so tired or less distracted. Or you can have those cases being read by two people if the first person doesn't pick up an abnormality. And you can, the other way of looking at it is you could use these same kind of triage tools to look at the cases with the lowest probability of there being a cancer present. And you could even ask the question, do they need to be read by a human at all?
Who's reading this mammogram? Because there's going to be a different reader every time I go and get a mammogram. It's not somebody who's looking at the same image. And for really early detection, a lot of times it's very, it's difficult to detect things that are very, very premature. If I can diagnose something on a mammogram, it's way beyond anything else. Anybody could look at that mammogram and go, that's a cancer. But in somewhere where you're trying to diagnose 3 millimeters of calcifications, then looking at one reader might see something completely different from another reader. I have a patient right now who went through an MRI, and I had a second radiologist look it over. I'm working with this other radiologist on an MRI project for screening breast. And the two of them, one recommended a biopsy and one said, no, that's fine, those are stable lesions. And that's a big deal for a patient to have two different readers and to have somebody say, this is suspicious for cancer, and say the other one say, absolutely not, this is totally stable and fine. And she's going to, does she need a biopsy or not? And that came into my decision because I'm the one who's trying to culminate all of the information together.
So I think artificial intelligence that is working with the radiologist. So it's the radiologist in the loop model, I think is really, really important. We know that radiologists make mistakes, and that there's been a number of, or they either don't perceive something or they do perceive an abnormality on an image, but they misinterpret it. They think it's a benign finding. And there's this blindness that people have for certain types of abnormalities, certain types of disease. So this is a really interesting area, and the error rates in radiologists are variable depending on what the imaging modality is and the experience of the radiologist, and also how the study's been conducted. But sometimes error rates are reported as much as 30%, which seems hugely high. So we need to help radiologists improve the performance for patient benefit. And so to have something which brings the radiologist, prompts the radiologist, and brings their attention to a particular feature in an image, which makes them look again, so they don't step over something because they're in a hurry or because they just haven't recognized it as an important abnormality, is really important.
The breast cancer models are probably the most well-developed of all of them for genetic risk assessment for cancer, as we have these sequencing techniques that make it cheaper and cheaper to do our whole genome, or at least for the cancer mutations, that those kind of models are going to develop for other types of cancer. I often recommend this for patients, a color genetic test, which is a panel of several hundred genes or so for cardiac risk and cancer risk. It costs $250. I think that a lot of people are doing those kinds of things, but they don't know how to interpret them yet. So this is going to be an increasing issue in our healthcare system. And a lot of the people who didn't get training in science in the cellular molecular biology or in genetics, because there just wasn't that much known, are really need some assistance.
Okay, so now we have Mihaela's presentation, which is sort of the main part of this session. I would like to point out that the experts who you just saw, many of them are actually on this session. So if you do have any questions or comments that you want to raise with them, please feel free to put them into the Zoom chat. And also, as you watch this presentation, please be thinking of any questions that you'd like to put to Mihaela, and please put them into the Zoom chat as soon as you can, so that we can kind of get a list of questions already kind of set up by the time we get to the Q&A session. And I would definitely encourage you to ask your questions, because that's one of the main points of these sessions. Anyway, next up we have Mihaela's presentation, in which we take these kind of problems and questions that were raised in the video you just saw and match them to ML and AI solutions through the use of academic formalisms.
We have heard so far from several prominent cancer specialists about the challenges they face in dealing with this complicated disease. Today, I'm going to describe how machine learning can help support them in these complicated decisions, as well as can support the patients with cancer they see. For this, I'm going to refer back to the framework which I have introduced in Revolutionizing Healthcare session number 2 for machine learning in medicine. This framework contained 4 pillars: bespoke medicine using machine learning, empowering healthcare professionals using machine learning enabled population health and public health policy, and machine learning enabled systems, pathways, and processes for healthcare. I believe that machine learning can play an important role in all these four pillars in supporting clinicians and medical professionals as well as patients with cancer. Today, I'm going to describe some of these technologies across the first four components of the cancer pathway: genetic risk, lifestyle factors, presentation, and diagnosis. And next time, we are going to continue with describing machine learning methods for the remainder of the cancer pathway. Let us start with genetic risk. In order to determine whether a patient may be at high risk of developing cancer during their lifetime, polygenic risk scores form an important point. And so far, linear models only have performed well on genomics data for crafting such polygenic risk scores. So an important question is, can machine learning help further improve the performance we currently have using polygenic risk scores that are crafted on the basis of linear models? And so far, only limited progress has been made in this important topic. I believe that the reason behind that is that we need to learn from very complex genomic data that has very many features, so it's very high dimensional, yet we have only very few patients for which we know both the genotypic information as well as the labeled phenotypic information. So we know for which patients they have developed cancer. It is complicated for machine learning to learn from such a wealth of genomic information while giving only few numbers of samples. So can we do better? Can we use data that we have available more effectively? And how? For that, we have recently used a new technology in machine learning called self-supervised learning. So what is self-supervised learning? It is a form of unsupervised learning. Let me remind you that unsupervised learning was different than supervised learning because it was not learning from the labeled data, like in supervised learning. And in self-supervised learning, we have no data, no labeled data that can provide supervision. So in general, we learn in self-supervised learning by withholding some part of the data and tasking the machine learning to predict this particular withholded information. So for instance, in imaging, we may withhold the right part of the image, and we may use the left part of the image to predict the withholded right part. Or in language, we may withhold the second part of a sentence, and we may use the first part of the sentence to predict the withholded second part. And in this way, we define the task, which we often call a pretest task, which is this withholding part, which will define a proxy loss, which will enable machine learning to learn what we really care about, the semantic representation and the relationships in the data, in order to solve these complex tasks. And in recent times, both for images as well as language, self-supervision has been shown to make great progress. However, self-supervision for genomics is a lot more complex because we do not have explicit knowledge of the correlations in genomics. For instance, across the different mutations and relationship between these mutations. So we need to learn the correlation structure from the genomic data. We have done just that in a recent machine learning framework that we have built that we call VIME. And VIME is a tool for crafting polygenic risk scores using machine learning. We are learning on the basis of unlabeled data representations using self-supervision. Then, using the labeled data, so whatever data we have that contains both genomic information but also phenotypic information, this represents the labeled data, on the basis of which we learn using semi-supervised learning. Semi-supervised learning combines a small amount of labeled data with a large amount of unlabeled data during training. However, in our VIME framework, we do not use just purely unlabeled data. We use the representations that we have learned using self-supervision. So we combine self-supervised learning and semi-supervised learning to learn from the vast amount of unlabeled genomic information, as well as the limited amount of data for which we have genotypic as well as phenotypic information. So when is this useful? In many settings. For instance, in many of the currently available biobanks, inclusively, for instance, the UK Biobank, we have a vast amount of patients for which we have genotypic information, but only a few of these patients have developed cancer. So we have a vast amount of genomic information that we can learn from, and we can learn representations using self-supervised learning, and we can combine that with the semi-supervised learning on the basis of the few available patients for which we have phenotypic information. Of course, we need to validate this in practice, and we have done such validation for a few settings only so far. And what you can see here is that VIME outperforms both state-of-the-art linear models used so far for crafting polygenic risk scores, such as ElasticNet, as well as a variety of other machine learning methods. So you can see that state-of-the-art in machine learning can indeed empower the crafting of polygenic risk scores. Again, a lot more needs to be done in validating these techniques in practice. Let us now go one step further and look at how we can incorporate a variety of other risk factors, inclusively lifestyle factors and sociodemographic factors, in determining risk for cancer. For that, we can use autoprognosis, which is the machine learning tool for crafting clinical scores that I have introduced in previous Revolutionizing Healthcare. We can use clinical data and build entire predictive pipelines formed of imputation, feature processing, classification, and calibration in order to issue predictions. Autoprognosis builds such pipelines automatically and selects the best machine learning technologies and the parameters associated with them at every stage of the pipeline for the particular data set. Autoprognosis does not only issue predictions, but also explanations associated with these predictions, such as the clinicians, medical researchers, and patients using these tools can understand them. Also, we can learn not only on the basis of the locally available clinical data, but also complementary cohorts from other hospitals or other countries, even if the genotypic information or the characteristics of these patients in these other locations is different. We are able to do that using transfer learning technologies. So when can we use autoprognosis? We currently have risk scores. For instance, in breast cancer, we have the Gale score or the Tyre-Cuzick score. However, these scores are using only a handful of factors which have been identified as potentially being important. But there may be a wealth of other factors that are important for various patients. And we would like to use autoprognosis to do two things. One is to identify out of a large number of potentially informative risk factors, inclusively socio-demographic information and other risk factors, which factors are most relevant for issuing an accurate prediction, thereby using autoprognosis to determine the value of information for a particular patient or class of patients. A second use of autoprognosis is understanding when nonlinear interactions between the identified factors is important, and we need to move beyond linear models to nonlinear models crafted by machine learning. So using autoprognosis, we can go beyond models such as Tyre-Cuzick or Gale by identifying additional clinical factors or genomic factors that are relevant for issuing a more accurate prediction for a particular patient, as well as the nonlinear interactions in which these factors need to be aggregated to issue a correct prediction. thereby issuing and understanding the value of information and the value of modeling. I have discussed the value of information and modeling in previous Revolutionizing Healthcare models sessions, so I'm not going to describe them again today. Also, we can issue competing risks, not only risk for one particular type of cancer, but also other related cancers, such as, for instance, the breast cancer and ovarian cancer, or different types of diseases, cancer and cardiovascular disease. In this way, we can better manage and prioritize preventive treatments, but also a determinate screening and screening profiles by adjusting cause-specific predictions. So machine learning methods for competing risks are often performing a lot better than existing statistical methods, such as cause-specific methods and the fine-grained methods for competing risks, because they can capitalize effectively on the complex data. I have described in a previous Revolutionizing Healthcare technology for building using machine learning solutions for competing risks. These are based on deep multitask learning. And the first part is using deep learning methods to do multi-layer modeling to capture the complex nonlinear representations of the patients and the way in which the features of the patients interact. And then at the second stage, do multitask learning, where the different tasks are associated with the different diseases for which we would like to predict correctly. Let us now move to the next stage in the cancer pathway, that of presentation of disease. And for that, I'm going to describe both the role of early diagnosis, for instance, in primary care, personalized individualized screening, as well as how we can use morbidities and comorbidities to potentially prevent cancer or detect cancer early. For early diagnosis, we are using the available healthcare data to build progression of disease, of health and disease trajectories. And this is very important in order to be able to identify cancer early in a patient. So what we are going to do is we are going to use machine learning and the wealth of input data available about the patient, inclusively symptoms, clinical findings, lab tests, possible treatments that are given to the patient, etc., as well as the timing of all of this, to issue predictions and forecasts, inclusively early diagnosis on onset of cancer, and potentially upon diagnosis, severity of disease, progression, etc. So for that, we need to use machine learning to build data-driven, accurate, and interpretable dynamic forecasting models that are personalized for the patient at hand and which can be used, again, for risk scoring, for early diagnosis, as well as prognosis. I have already described in Revolutionizing Healthcare 3 different ways, different formalisms for doing time series analysis and dynamic forecasting. I'm here today only going to briefly revise some of the key concepts because they are relevant for cancer. So for instance, to build disease progression models for cancer, we need to understand and model carefully the available data. I'm going to describe that next. Upon having a model, we can learn the parameters on the model from whatever data we have available, for instance, electronic health records data. And we do that offline at training time. Then at runtime for the patient at hand, we are issuing on the basis of such trained disease prediction models, dynamic forecasts that are bespoke for the patient at hand. In this way, we are not only able to build decision support systems for clinicians and patients, but also unravel new understanding of disease progression at the population level, but also identify, for instance, whether different classes of patients may progress towards a cancer in different ways, and also be able to understand how the unique characteristics of a patient may play a role in the evolution of the health and disease trajectory of the patient, inclusively prior to developing cancer, as well as after the patient has developed cancer. One particular way in which currently people are modeling health and disease progression in cancer is using Markov models. I've described Markov models in a previous Revolutionizing Healthcare session. If you are interested, please take a look. Markov models are compounding the entire history of the patient into the current state. And this represents often state-of-the-art models in modeling cancer progression. Also, you can see here another example from the specific case of prostate cancer. And more generally, this is modeled using different types of stages and the time at which the patient either was diagnosed with cancer, which represents then the absorbing state, or upon diagnosing with cancer, the absorbing state and the progression to the absorbing state may lead to recurrence, and the absorbing state may represent death. However, a disadvantage of these Markov models is that they assume that the different stages of the disease are all observed and annotated. However, very often we may have symptoms or comorbidities associated with the patient pathway, but we may not know whether the patient has already cancer. The cancer may be diagnosed only much later. So an important disadvantage of using these models is the fact that we cannot learn unless we have observed every part of the cancer pathway and the evolution in a patient. So instead, a more effective formalism is the hidden Markov models, where we learn on the basis of whatever observations we have available, symptoms of the patient, lab measurements, results of different screening, treatments, comorbidities. So we learn from the wealth of observation the underlying hidden state of the patient. This may be a healthy state or a preclinical state or a particular stage of cancer. In this way, we can learn a much more systematic categorization of the pathway that the patient is undertaking before cancer and after the cancer has formed in the patient. And what is good about this type of formalism is that we have the probability associated with different types of observations in the different stages and the different hidden states. So we can see that if we see a particular symptom exhibited with a high probability at a particular moment in time, this is representative on the underlying hidden state associated with the cancer pathway. Also, we can learn in this way for different types of patients that may exhibit very different types of diseases and different types of cancers. We know that cancer is a very heterogeneous disease, as our clinicians have mentioned, and we can learn how the different patients with different characteristics are evolving over time differently, and what is the symptoms that they see and the comorbidities they see over time, and be able to better characterize different types of cancers, different types of progression of cancer in different types of patients with different characteristics, for instance, genotypic information or other type of social demographic factors. If you want, we can go one step further and use semi-Markov models, hidden absorbing semi-Markov models, which I've also described in the previous Revolutionizing Healthcare session, where we, on top of the fact that we are using hidden Markov models and hidden states, we also consider the duration in the past state, which will affect the transition to the next state. So unlike in the hidden Markov models where only the current state matters, now it is not only the current state, but also the duration in that particular state that matters. This is important for characterizing disease because potentially a patient may have had a particular morbidity or comorbidity for quite a large amount of time. And if that remains untreated, then this may turn into a cancer. So the duration of that particular morbidity and comorbidity will matter as well. We can move one step further and use the entire history of the patient. So not only the current state and the duration in the current state, but the entire history so far, thereby being able to capture complex non-stationary representation of patient-level trajectories. And we have done that using a machine learning model that we called attentive state space models. In this way, we learn over time the weights that influenced the past state realizations and how this past state realization and the journey of the patient so far has led to the patient moving to a next state at a particular moment in time, thereby providing us with better disease understanding and as well as better models for forecasting of cancer. So how can we use these types of models to diagnose cancer early? We learn on the basis of whatever healthcare data we have available. For instance, a patient that was here diagnosed with stage cancer free, so unfortunately quite late, and we have other information about this patient, like symptoms that have occurred and when they have occurred, as well as morbidities diagnosed and when they've been diagnosed. We learn on the basis of whatever data we have available using such machine learning models. Then, for a new patient, when they are coming, we learn on the basis of these predictive models. And when we see that they develop, for instance, in a particular moment in time, a symptom like the one shown here, we know that they may have a quite high chance of developing first a particular comorbidity, which may then lead later to cancer. So we have the opportunity to screen this patient more effectively and more carefully to detect whether this comorbidity will indeed occur, and also possibly treat this comorbidity such that the patient may not develop cancer. Also, we can determine when and how to screen on the basis of these models, thereby hopefully detecting cancer early. Related to the topic of personalized screening, we are moving using machine learning from a one-size-fits-all screening to a personalized screening, but also dynamic screening. Currently, patients are screened for cancer, for several cancers, at either age 40, 50, or 60, depending on the type of cancer and the country they are seen. But we can move one step further. We can move into a personalized screening where, depending on the variety of factors, inclusively family history, genomic information, but other social demographic factors, we can determine when to screen the patient. Maybe some patients are screened much earlier and some may be screened later or not at all. But also we do that dynamically. So we do not only say these patients are high risk, hence we need to screen them earlier. We also look at the past history of symptoms of these patients as well as past screening results to determine when to screen the patient next. This is what we did in this technology using machine learning that we call DP Screen that we have developed a few years back. We see here 3 patients, for instance. Patient 1 and patient 2 have the same features, but have different histories. So for instance, these 2 patients have similar family history, but their history of symptoms and screening so far has been different. Hence, they need to be seen at different moments in time and possibly given different types of screening. Also, you see here patient 2 and 3, which may have the same history of screening and similar results, but because they have different risk factors, for instance, genetic risks, they will need to be screened differently. So we have personalization through features, and when should these patients be screening next is determining on both, depending on the features, unique characteristics of the patients, as well as the history and past history, clinical history, as well as the screening history. Now, let's see how we can use morbidities and comorbidities to either identify cancer early or even better, prevent cancer. Currently, morbidities and comorbidities are modeled in a one-size-fits-all way and a static way, often using networks of relationships among these different morbidities. Instead, using machine learning, we can personalize their morbidity networks depending on the unique characteristic, for instance, genetic information of the patient, but also we can do this dynamically. So depending on the order that these morbidities are occurring, we can predict the probability of developing a new morbidity or cancer in the future. So we are able to learn dynamic and personalized comorbidity networks for cancer using event data and a variety of other data using machine learning methods. Here, we are showing the use of a deep diffusion process, which is a new technology we have developed last year. And we have used this technology on the basis of the UK Cancer Registry to see how personalized comorbidity networks for cancer occur. This deep diffusion process is able to model the temporal relationships between the comorbid disease onsets expressed through a dynamic graph. Again, depending on the timing of the different morbidities and comorbidities, the duration, the time at which they were untreated, we can predict the onset of a new disease, inclusive cancer, early. Let us now move to the next stage of the cancer pathway, diagnosis. I have already described in a previous Revolutionizing Healthcare session the use of MAMO, which is a framework for radiologists and machine learning to cooperate. This work was done in cooperation with Professor Fiona Gilbert. The focus of MAMO, which I will not describe in detail here today because it was described previously, is to triage mammograms between machine learning systems and radiologists. Whenever it is believed by the triaging system, which is itself a machine learning method, that given the unique characteristics of the patients and the characteristics of the mammogram, this mammogram will be correctly classified by a radiologist. This mammogram is then sent to, by a machine learning system. This is sent to the machine learning system. Conversely, when it is believed by the triaging system that the machine learning cannot confidently assess this mammogram, it is sent to the radiologist. So using triaging, we can relieve the high load of radiologists and only send to them the mammograms that the AI-assisted system cannot classify accurately. Also, we are able to show using MAMO that often for different types of mammograms, man and machine need to cooperate. The radiologist needs to cooperate with the machine learning system to identify different types of characteristics of the mammogram in order to achieve the most confident and accurate prediction. So the clinician may be able to assess different types of factors than the machine learning system. So there is scope for collaboration. We have done this study for the sake of mammography for breast cancer, but similar frameworks can be used for other types of cancer to empower radiologists to cooperate with machine learning systems. In yet another previous work, we have built a system that we call Confident Care, which is a machine learning clinical decision support system where we are identifying what type of screening modality we should use for this particular patient, given their unique characteristic features, inclusively, again, genomic information or past history of screening. Shall we do a mammogram, an ultrasound, or an MRI? And we can learn what best technology to use for the screening of this patient at a particular moment in time. This type of technology, again, is very powerful and useful because often for different types of cancers, different types of modalities for screening can be selected. And this can help clinicians recommend the best test suited for the patient given their unique characteristic. Finally, I would like to turn to one of the most complicated parts of the diagnosis and treatment plan process for cancer patients. That of building multidisciplinary teams to determine what's the best way to treat this particular patient. We can use, in this case, machine learning to build recommender systems to identify which particular characteristics of clinicians, what clinicians should come together to best decide treatments and interventions and pathways of care for this particular patient, given their, again, unique characteristic, given the information that we have about this patient. So a few years back, we have built a recommender system that is able to discover the expert based on the context of the patient. And this will select what characteristics of clinicians in the multidisciplinary team we need, and also potentially what type of machine learning methods, clinical decision support tools can assist this multidisciplinary team of clinicians to issue the most effective plan for the patient at hand, given their unique characteristic. So what you see here is machine learning is being used as a recommender system to identify referral and composition of such MDT teams. So unlike the current use of recommender system that you are familiar with, recommending to us what movie to see next, or on Amazon what product to buy, here the machine learning method is learning what type of experts should be put together to best assist this particular patient and provide the most effective plan for them. I discussed today the first 4 parts of the cancer pathway. Next time, we are going to move to the subsequent paths, and we are going to talk about treatment, follow-up, possible recurrence, and continue with the patient pathway. Thank you. We have heard.
All right, so now it's time for our Q&A session. So I think we actually have all the questions we can possibly handle. So I'm afraid we're probably going to have to close up to any subsequent questions. So basically, when I call on you to ask your question, I'll also ask you to unmute yourself. At that point, please just identify yourself. And it would be great if you could keep your question to within 1 minute so we can have 3 minutes per question and answer. And then please remute yourself afterwards. But to start with, I think we have a question for one of our experts, as well as Mihaela, which is for Fiona Gilbert, and it's from Tom Daniels. Tom, if you could go ahead.
Yeah, thanks very much. I hope you can hear me all right. Yeah, it's for Fiona and Mihaela, really. And obviously, machine learning has got great potential and maybe more accurate in terms of diagnosis. But if it does provide more accurate diagnostic predictions, do you think that might change radiologist behavior? And if so, how can you make sure that there aren't unintended consequences of introducing this new technology on radiologist behavior? So it's that sort of downstream consequence I'm interested in. Thanks.
Tom, I think that's a really, really important point you use. And I think that we have absolutely learned from the past in that computer-aided detection does change radiologist behavior. So the radiologists tend to become more dependent on whether or not a machine is giving a prompt on an image. And if there's no prompt, then the radiologist will tend to dismiss the image as being normal. Whereas we know from previous work with CAD in the last kind of 10 years that in fact it can end up decreasing the performance of a radiologist if we're not very careful. So what we absolutely need to do is we need to ensure that we do prospective testing with the different algorithms. We need to make sure we get the best algorithms first of all, and then spend the time seeing how how the radiologists interact with it and how it affects that particular radiologist's performance. Because different algorithms have different strengths in the same way different radiologists have different strengths and blind spots.
Also, just very briefly, Tom, just to add on top of Fiona's answer, in the systems that we are currently building, increasingly we realize that it is not necessarily that the machine learning system is going to necessarily serve as an aid always. It may also serve at times as triaging. So simple mammograms, routine mammograms may be never seen by the doctors. So potentially one solution could be that the radiology, the imaging that it is routine will never be seen by a human. Also, one other solution could be that machine learning can potentially not necessarily retrain, but keep sharp radiologist, because it can say, I detected this particular lesion or this particular conspicuity or this particular effect in the image that may be useful for you to take a look. So maybe it's not only decision support, but also potentially a collaborative tool where the machine can keep the radiologist trained and ready to pay attention to various things. Because from the work we have done with Fiona, we can see that the radiologists and the machine learning methods are having different strengths at times. It is not, for the complicated imaging, they have different strengths and see different things.
Okay, so I guess if we can go back to sort of chronological order in which the questions were asked, I believe our next question would be from Vasilis. Please go ahead, Vasilis. Actually, it's two questions, and if you wouldn't mind sort of trying to combine them, well, not combine them, but ask them both.
Sure.
Yeah,
thank you.
Go ahead.
Great presentation. Thank you very much. I mean, one of the question is essentially on how do we use data from multiple institutions to basically improve prostate cancer screening programs. And because, as you know, we can't run massive clinical trials, are very expensive, so we can harness the power of the data to then recapitulate the disease history and then decide how screening is going to be designed. And then as a sub-question to that, would it be possible through a multi-progression model, when you're building those models, to actually infer some causality? So if you have, let's say, some genetic information along the way, would it be possible to say, right, we know that a precipitating biological event happened in this particular time point?
So thank you very much, Vasilis, for both questions. So in the hidden Markov model, for instance, that I have shown, and the advancements on top of it, the attentive state space model, the hidden absorbing semi-Markov model, as you see, we have a variety of tests and test results or symptoms. So it could be that initially, in the beginning, we have information that was acquired, for instance, from a general practitioner or primary care clinician office about symptoms and a patient having certain kinds of symptoms. Then we can have maybe some imaging that has been done based on that referral. And like you say, the problem is, of course, a practical one to require all this information to be gathered together. But if we have access to that information, what is interesting about these models, hidden Markov models and plus, I should say, and beyond, is that they can learn what is the probability of seeing a particular type of result from imaging or from a lab test or even a symptom at different stages of disease. And the way in which we are doing that is we see, for instance, as a patient was diagnosed, for instance, with a cancer at a particular moment in time, at a particular stage. Then at training time, we go backwards in time and we learn what symptoms or what tests have been done on this patient. Was there anything in the history of this patient that could be interesting? And we overlay that across all the patients that we have in our data set. And we learn on the basis of this. But also we learn in the case we have no observations. We may have just very few observations for a particular person. So, but we may have genetic information, for instance. So then at runtime, at test time, if you like, after the system has been trained, we are going to really have, for a new patient that may exhibit a particular symptom or may have a certain genetic information, we can issue predictions of symptoms. Do we see a certain set of symptoms when we expected them to see? And can we predict early that this person may be developing a morbidity or a comorbidity that may be related to cancer and then subsequently to cancer? So the answer is, in this Markov models, the observations could be anything. They could be imaging findings, they could be symptoms, they could be lab tests, they could be loss of weight, they could be other things. And we can integrate them over time and then see what is the probability associated with a particular state. But this is a predictive model. This is not a causal model. Causality is hard, but it represents the frontier, if you like, in machine learning currently. So as we speak, a variety of machine learning efforts are happening where people are starting to look at can we really build causal models? The struggle here is, ideally, we would like to have causal models over time. So causality is currently a lot focusing on, does this particular genetic mutation or does tobacco cause cancer? What we are interested here is to go beyond the static causality problems into dynamic causality. Is this event triggered this other event, and this other set of event has indeed triggered cancer? So look at causality in the time series setting. And this, as I mentioned, is important, and machine learning is, I would say, is the cutting edge of machine learning right now, and methods are being developed as we speak, but yeah. Thank you.
Okay, so next up, I think we have two questions from Nawal as well. And if you wouldn't mind as well, just kind of, asking these within the same window, that would be fantastic.
Yep, sure. Thank you for the talk. It's been very insightful. So it's been said that the NHS is really slow to adapt to new technologies, particularly AI models, and that's probably mainly because of the lengthy regulation process. So what would you say to doctors or medical students that might be a bit hesitant to join this field because of the lengthy, again, as I said, regulation process and the uncertainty whether their work will make an impact and whether it be introduced into practice? And also, what do you think would be the first step for a medical student like me to get involved in AI?
Thank you, Nawal, for joining and for the question. So first, I will not comment on how fast or slow a particular organization such as NHS is in adopting this. Instead, let me issue another concern. My concern right now is that we do not have good processes in place to understand and validate AI systems and their efficacy. I think the NHS and other such organizations would need to have very clear review processes in mind that indeed include a variety of stakeholders, from patients to clinicians to true machine learners. And in that regard, my worry is another one. I'm seeing a lot of discussion about machine learning and AI systems being adopted by all sorts of organizations. And these methods are often not state of the art. We can do a lot better as a machine learning community. So a fear I have, and part of the reason that this Revolutionizing Healthcare sessions focuses on methodology, is to expose to you, the clinicians, a variety of options, because I think too often simplistic AI methods, which are cooked up by people who with relatively limited machine learning knowledge, are developed. And then the entire AI machine learning community may get a bad reputation and a bad name because the focus is on simplistic solutions rather than what the AI community, I would say, can offer at this moment in time. So hopefully, indeed, as clinicians like you are going to be more aware of these different technologies, they can shape them. So with respect to how to get engaged and how to learn more about machine learning, well, it depends really on your appetite. One solution is to remain engaged with us. You are going to see a variety of methods and technologies through Revolutionizing Healthcare. But also there are a variety nowadays of machine learning courses that are available for clinicians that are interested in machine learning. I would say, though, that I do not believe that it's necessary for clinicians to become geeks and learn all the details of machine learning. I think that that's unnecessary, and also the field is moving at a pace at which is probably not reasonable to keep up with all these technologies. Instead, I feel it's a lot better to understand the key concepts and formalisms, such that then you can demand from your machine learning colleagues or from companies that you are engaged with, what is the technology that you really would need to solve the type of problems you have in mind. So the focus on these formalisms and these methods is to give you a high level overview of what's possible, such that you can take then this to your own problems and your own needs.
Okay, so I believe next up we have a question from Bing Wang. If you want to go ahead.
Hi, can you hear me?
Yes, yes, I can.
Okay. Hi, I'm Bing. Thank you. Great presentation. I'm one of the EPR senior configuration analysts at Great Ormond Street Hospital for cancer. And so like my question is, are these machine learning modules only applicable to adult cancers, or are they also applicable to pediatric cancers?
So definitely the technologies that I'm describing here are not special to a particular type of cancer or patient group. Instead, they are applicable to pediatric cancers as well. More than that, and I'm going to discuss this more in the next session, it is my hope that heterogeneous diseases such as cancer can be better understood in terms of their diversity using machine learning. So definitely what is interesting here is the progression, for instance, of a cancer in an adult different than a cancer in pediatric patient? Is a particular type of cancer in a person with a particular genetic mutation different? So we are trying to understand the diversity and complexity of cancer in different subpopulations and understand whether, for instance, again, cancer goes through a certain number of stages and states in one population and subpopulation, or potentially a different number of stages in another subpopulation. And more than that, are there different types of observations or symptoms that we make for these different classes of patients? So trying to understand the heterogeneity of cancers in both adult as well as pediatric population, as well as in different subtypes of populations, is what I do think these tools hopefully can offer, such that we understand better why two patients, even though seemingly similar, are going to progress in very different way. So sorry for the long answer. So the answer is yes, these technologies can be applied to pediatric patients.
Okay, so I think we had a couple more questions, but the people who asked them are no longer with us. And I guess we've also kind of hit the point in time when we'd want to wrap up anyway. So before I go, however, there's just a couple other points. So as I mentioned earlier, our next Revolutionizing Healthcare session is at the end of February, specifically the 26th at 4 p.m. UK time. And of course, I'll be sending out lots of updates related to that as we get closer to the time. As I mentioned, the focus will also be on cancer, but this time we'll be looking at the post-diagnosis parts of the pathway. A kind of similar format to what we had this session, in that we'll present the problems and questions, and then we'll address them through the use of formalisms that connect to AI and machine learning solutions. And we'll also have another open Q&A and discussion when done. Just another couple notes. For those of you who'd like to claim CPD credits for attending, please drop me an email at the address you see on the slide, or you can just reply to any of the emails that I've sent regarding Revolutionizing Healthcare. When you do so, please just mention which session or sessions you've attended. I'd also like to mention that you can actually claim credits for archived sessions on YouTube, and this includes the last session we held, which was in December 2020. So what then we will do is issue you with a CPD certificate that allows you to apply via the Royal College of Physicians CPD website. And you can search that site by date or event name, but if you need to, we will also provide specific event codes for you. And another request just from me, please, if you do have any friends and colleagues that you think would be interested in these sessions, please let them know using this URL on the slide you see here. Again, of course, we're trying to build a community, so word of mouth is extremely important to us. Other than that, thank you all so much for joining us today. Thank you very much for your questions and your input and insight. And also thanks so much to the clinicians who volunteered their time to talk to us ahead of these sessions. Really appreciate it. And very much looking forward to our session in February, again on cancer. In the meantime, please take care, stay safe, and all the best.